Well, hi everyone, and thank you so much for joining us wherever you are in the world. Delighted that we have esteemed academic, amazing clinician, and just a really wonderful person who I absolutely adore, Dr. Ruth Lanius, that I'm going to be chatting to live today. Hi, Ruth.
Hi, Tracy. It's great to be here and welcome everyone.
So nice to be with you once again. So, Ruth, we're going to talk, trauma, PTSD dissociation, and I guess it comes at a time no better like right now and what's happening with sort of our global state right now. Let's take a deep dive into trauma and, you know, tell me a little bit about, with you being such a leading clinician looking at at trauma, brain networks, neuroscience, how has sort of the latest neuroscientific developments really changed trauma treatment today from what we sort of knew maybe 10, 15 years ago?
I think that's a great question, Tracy. And I think it's really a two-way street. And I think that's something our group has really learned. So I think it's really about what has neuroscience learned from the individuals who are suffering from trauma, and what have the individuals suffering from trauma and the clinicians learned from neuroscience. And what I can say from my own experience, everything I've studied in neuroscience has really come from my patients. So their individual experience has really inspired me to do the neuroscience research. And, this dates back to seeing very different responses to trauma. Some people had this too much emotion, too much arousal response, and other people shut down, they detached and had too little arousal. And all that came from my patients. And of course, then, we have a lot of advancements in neuroscience that have really helped us, I think, to make the invisible wound of trauma visible, right? We have beautiful imaging techniques where we can now look inside the brain and actually see, how the brain fires when people recall traumatic memories or when they're engaging in social interactions, which is very difficult for traumatized individuals, for example. And so we've been able to make the invisible injury visible. And I think that's been incredibly validating for a lot of individuals suffering from trauma. Because as we know, we've come a long way in mental health, but there's still a lot of stigma, right? And so really being able to show, look, this is different as compared to a brain image from someone that hasn't been traumatized, I think has made a huge difference. And then in terms of how has neuroscience informed our clinical practice, and I think what we're really moving more towards, and we're going to talk about this in the course that is upcoming, is how we can really help the brain guide the treatments that we do. Identifying some of the key brain networks, for example, like the resting state network, the default mode network, that's so related to our sense of self. And we know that that sense of self is often shattered in the aftermath of trauma, or it never develops as a result of developmental trauma. So knowing how that network is affected in trauma can help us then guide treatments. Or another network would be the central executive network. So the network we use for thinking, planning, concentrating, remembering things. And we know that our patients really have huge difficulties, focusing on a task, remembering. And so again, we know that this network is not fully functioning in trauma. And so how can we then use that knowledge to guide specific treatments? And I think that's a really exciting area in psychotraumatology right now.
Mm. And I think what you're saying, Ruth, is like, I don't know, I'll just sort of say it in my world. It's like, how do we almost like make neuroscience super sexy? So what does it kind of look like when we are working, when we are sort of doing clinical application of, yeah, all these things are happening in the brain, but how does that kind of translate into therapeutic practice? So tell me a little bit about, yeah, sort of your thoughts from everything you've said around what's happening in the brain and what does that kind of look like now in, clinical intervention, trauma treatment?
Yeah, and I think one thing that we're really thinking about more and more is that sense of self, right? And how important that is in trauma treatment, and how that is really the thing that we need to change, right? And restore. And when we think about some of the newer treatments that we often use adjunctively, for example, neurofeedback or psychedelics, both of those treatments really think about that sense of self and how we can restore that and slowly bring that back online. And as we do that, and of course, the psychedelic researchers and clinicians also think about that, as we repair that sense of self, self-compassion also comes online. And I think that's something that's one of the most difficult things to really bring online in trauma treatment, right? Especially when individuals feel a lot of shame. These are exactly the individuals who get stuck in trauma treatment. And so to think about how we can shift that, how we can get somebody to look at themselves and think, I'm not so bad. What I did wasn't so bad. And, I deserve some good things to happen to me. And how that can change the brain networks, right? How we can uncouple, those deep reptilian structures that drive those raw negative affects or emotions, and that negative arousal, they get coupled to our sense of self, those deep areas, and how we can uncouple those two areas so the sense of self can now flourish and no longer be driven by those raw affects and by those trauma-related arousal systems, I think is key to really free that sense of self in the aftermath of trauma. And really, every treatment we use, I think, does that in one way or another. And I think what's very exciting is especially in the individuals who don't respond well to one treatment, is how can we integrate those treatments? And of course, that's going to be a focus of the upcoming training. How can we integrate those different treatments to really free that sense of self after trauma?
Hmm. And I'm just reminded because if we go all the way back to someone like the lovely Aaron Beck, who recently passed away, I think it was last year, and back in the 50s and the 60s when he was putting together the cognitive behavior model, and he was
Yeah,
talking about that, the sense of self, the belief about the
absolutely.
self, the world, the future. It
Yeah,
sounds like what you're saying is that kind of evolution of understanding, well, how do individuals, first of all, come to have that sort of not so good sense of self, but now we're really understanding actually what then perhaps gives those schemas and how we can restore that through specific treatments. Is that kind of what you're talking about?
absolutely. Right. And Beck and Edna Foa, I mean, they were pioneers in this to really identify those negative thoughts. And what we're seeing now in the brain is that it seems to be those raw affects deep within the brain, very low within the brain, in the reptilian brain, that are driving these thoughts, right? So we feel very negatively about ourselves, and that really reinforces how we think about ourselves. And I think as clinicians, our patients often come into our office after they've had some treatment, and they say to us, I know I'm not a bad person. Like, I know that cognitively, but I can't stop feeling it. Right. And I think this is the next frontier of trauma treatment, that we really get in those patients who have that difficulty to get really deep within those brains and really change that raw affect that often is more difficult to resolve, and then through that change how people perceive themselves.
Hmm. And Ruth, your clinic and what you do, you work extensively with the latest treatments in terms of your clinic and the research that you do on PTSD and brain networks and trauma. Talk about some, I don't know, uh, the treatments that you think are really sort of right on the button right now that every single therapist should really have as part of their clinical toolbox?
Well, I'm really a proponent of an integrative approach, as you know, Tracy. And so, I've been trained in CBT, of course, in psychodynamic approaches, in DBT, in sensory motor approaches, in the SMART approach, in neurofeedback. I'm doing a psychedelic training. And what I've really learned in my clinical practice, which consists of people who've had difficulties, getting well from, standard treatments, is that integrating these different treatments and really identifying areas of stuckness in trauma treatment are critical to helping the individual heal, but also helping prevent burnout in therapists, right? And I think the more we can, and EMDR is another important treatment that I missed, for example, the more treatments we have available, the more tools we have in our toolbox, right? I think the better we can intervene and really, look at the individual in front of us and personalize that treatment. I think that's so critical. And that's something we're going to talk a lot about in the training. How can we personalize the treatment? What's going on with each individual? How are they different? And how, would they best fit the different treatments in a personalized approach?
Mm.
And so I would encourage everyone to have as many therapies at their fingertips if possible. And I think they'll have a much more fulfilling career and they'll suffer much less from burnout.
Mm. Now, you've been talking about sort of this course, and you and I have been working long and hard this last year to really put together everything that you've said into one comprehensive, state-of-the-art trauma treatment, trauma PTSD dissociation course. Ruth, say a little bit about, what made you choose some of the great speakers on this list, from, Carlin Lyons Ruth, to Gabor Mate, to Pat Ogden, Janina Fisher, Sabern, talk a little bit about your thinking in terms of bringing these 30 or so experts into this amazing certificate program.
And it's been such a pleasure to work on that with you and, of course, with the speakers. And I think it's really taking a bottom-up approach, and here with attachment, right? So understanding the key role attachment plays in the development of emotion regulation, being able to be present, and in the development of the sense of self. And, we've got some amazing people like Carlin Lyons Ruth, who has these prospective studies over 25 years. She's followed caregivers and their children. And we can see how, when a caregiver is not in tune with a child, for example, and when the child doesn't feel safe with the caregiver, how severe dissociation can develop outside of the presence of physical and sexual abuse. And I think that's so important. And it's something that I think we haven't faced enough as a field. And then, of course, we have Alan Shore, who's been an incredible theoretician in really describing, that foundation of the attachment and the development of the sense of self, and how that, dissociation fits in here as well. And then we have Benny Farina from Italy, who's worked very closely with Liotti, who also really understands brain development in the context of the attachment relationship. So that forms the basis on which I think trauma often is experienced, right? Often individuals have these profound attachment difficulties where they didn't have a caregiver that felt safe to them. And then I think they're also at higher risk of experiencing certain types of trauma, and which then have an even more profound effect because that foundation of emotion regulation and sense of self hasn't been allowed to form appropriately. And then we have, often people refer to it as big T traumas on top of that, that can have more profound effects. So how can we see all those difficulties in the context of attachment, not just for understanding of the individuals that we treat, but also for the treatment, right? Because we're going to have to really embrace that, I think, in our treatment of these individuals and in our understanding of these individuals.
So it seems like what you're saying, that if you are a therapist or a clinician or a body worker or an academic, and you're working with people who have things like anxiety, depression, PTSD, perhaps a diagnosis of bipolar or borderline or DDNOS, or perhaps even ADHD, or in some capacity, depending, any kind of attachment disorder, then this is a comprehensive course that can really help people get into, take a deep dive into some of these, as you were saying, how some of these sort of perhaps diagnoses or issues might come about.
Absolutely. I think you hit it dead on, Tracy. And we're going to move away from labeling people. I mean, of course, we're going to understand, what diagnosis they have, but we're going to move away from labeling people and really understand each symptom in the context in which it occurred. And I think that is a very critical factor in really facilitating personalized treatment.
Mm-hmm. Mm-hmm. Yeah, so I'm aware we've had some questions come in, so I'll ask a couple more questions before we sort of see the questions come in. So do pop the questions in, and thank you for those who have submitted questions. And Ruth, I really kind of, I really like that idea of, in some ways, moving away from diagnosis, knowing that it's very, very helpful. It allows us to sort of see certain things that and sort of personalize treatment in a way. So it becomes, I know there's a big thing about sort of precision medicine, and I imagine it will become about precision mental health in the future. But this course, I think what you're saying really speaks to that kind of more personalized take of what might be going on with someone, regardless of their diagnosis or something perhaps that they've been told by a medical professional.
Absolutely. And I always teach this to my residents and other people I work with. And I say, we've got to figure out the diagnosis, of course. But then just as important is figuring out what's the most essential difficulty that is keeping this individual from functioning fully in everyday life. And we really need to understand that. And I think we need to target that in treatment, right? Because that's what's going to get somebody unstuck and really, get them to flourish and thrive in everyday life.
And so by, bringing that together, finding out what is that thing, is it in the attachment system? Is it a big T trauma? Is it a small T trauma? Is it, by just having that kind of more precise focus, this course and learning and then having those sort of clinical conversations with the experts is going to enable people to have more of a personalized sort of treatment toolbox to be able to potentially help these people in their practice.
Absolutely. And actually go to your practice and know how to do that, right? Because, we have all heard, wonderful things about, all these great treatments we have for trauma, right? But it's often difficult for us to know, okay, well, what would I do? What would I do with this treatment? And then how would I bring another treatment if the one treatment doesn't work fully? And how do I do that? And I think we're really going to discuss that in this course, especially in the interactive sessions that are occurring weekly.
And I must say, as a clinician myself, I absolutely love this about the course, because exactly what you're saying is that, people can be live with the experts such as yourself thinking, hey, I've got this happening, I've tried this and this and this, and then get that kind of personalized narrative straight from the expert around, okay, well, this is what it's saying, and this is how you apply it in your clinical practice.
Yeah, absolutely. And I think we're all going to learn together, right? This is going to be a community where we all learn together. I always learn from the individuals that I work with. And that's the kind of atmosphere I think that we're really trying to create, right? It's a non-threatening atmosphere where we support each other and we really learn from each other. So I really look forward to that.
Hmm. And I know there's some questions happening somewhere. So, Rachel, if you just also aware of time, if you can send them through. Ruth, I did have a little question for you before we see those
Yeah.
questions come. Who are you really looking forward to on this program? I mean, I know it's hard to say because there's just so many great people on this program, but who are you looking forward to having and speaking to and hearing from?
You know what? Every single one of them, Tracy, and that's why I picked them.
I knew you'd say that.
I think they're all wonderful trauma therapists. They all care deeply about what they do. They're passionate about what they do. And I think they're all, yeah, going to be wonderful. So I can't single anyone out.
Damn. And perhaps you're really at the forefront of trauma treatment, and one of the things we've started to see is sort of like a really big interest, actually, in the UK here, in the US, and globally, around sort of using psychedelics. We are in this course doing sort of bottom up treatments and that sort of thing, but any sort of thing, are you excited about sort of combining psychotherapy, psychedelics with normal psychotherapy, and just sort of bringing it in as a way in, or anything you're seeing that you think, wow, that's super interesting?
Absolutely. And of course, I'm excited to have Mike Mithofer and Dick Schwartz discuss that. And I'm currently doing a training in, psychedelics in PTSD. And I think it's very exciting. And what I see from patients is that self-compassion that we talked about earlier often can be accessed through the use of psychedelics. So that connection with certain parts of self that have really suffered and that we've really been judgmental about and afraid of actually facing, right? And of course, Dick Schwartz calls these the exiles. And that, the psychedelic treatment really opens up the capacity, right, to have more compassion for these parts that are within us and that often have a lot of pain. And so I think it's a very exciting new tool that we will have in our toolbox in the future. And I'm thrilled that this will also be part of this course.
Hmm. And with that said, again, you probably might be doing this research in your lab, but is it because certain brain works are able to sort of step back in practice when there's sort of use of psilocybin or something else? Like, do you know what's happening in the brain, or we're not quite there yet? What allows that sort of capacity of more compassion, or the person to be, maybe less activated in terms of the exile? Do you know what I guess that sort of key mechanism is, or there's still further research happening?
I think there's a lot of good research happening, and Carhart Harris is actually looking at that sense of self network and how that can be affected by psychedelics. And if I had to hypothesize, I think what we're going to see is that we're going to see an uncoupling of those negative affects and those negative trauma related arousals driving the sense of self, and therefore freeing it up to, be more compassionate and less negative.
Wonderful. Ruth, it's almost time that I hate saying goodbye to you, because it's just always so good to connect and hear where you at and hear what you've got going on. And I can't wait to see you on this course that we've got with you, and with it starting on the 1st of April. So I can't thank you enough. Thank everyone that's joined us today, and really looking forward to the program starting on the 1st of April.
Thank you so much, Tracy, and I so look forward to it as well. And I really look forward to our discussions and learning together. Thank you.